and we have one of the top figures to be a moderator tonight, Dr. Muhammad Mustafa. Dr. Muhammad Mustafa is a role model consultant anesthetist in UK. He graduated from Banha University in Egypt, and he moved his way to the top career. Now he is a consultant anesthetist in North Cumbria Integrated Care Foundation Trust in UK, and he is the lead of the regional anesthesia surface and acute pain consultant in UK. You know, the Egyptian, when they go for that road, they don't stop, and nothing stops their career till they reach the top of the pyramid of the career. Dr. Muhammad Mustafa is honoring us tonight by his presence and going to lead the webinar. And God bless the speakers for his questions, because he is very knowledgeable and very kind for taking this webinar tonight. Dr. Mustafa is all yours. Thank you.
No, thank you very much, Dr. Saad. Thank you, thank you, thank you. It's too much pressure on me now. However, good evening, everyone. It's 7 p.m. in Cairo time, and it's one of these Sundays which we owe a lot of anesthetists around the world now, I believe, used to convene and join in this fantastic, really, platform of learning, engaging, and interacting with top-class speakers and faculties who are really used to spread their knowledge and experience among us. Just as Dr. Saad mentioned, it's just to remind you all that we are available on different social media platforms. We are available on Facebook, in Twitter, and also the super Dr. Saad, he keep uploading the lectures on a YouTube channel. So don't forget to visit the channel. Also, don't forget to visit the fantastic free website, which offers a diverse range of free training materials, articles, and videos. So it's my pleasure for tonight to be, as for the first time, to be as a moderator. I hope I will doing well. And I'm having three speakers. Two of them are based in the United Arab Emirates, and it's my lovely country where I used to be raised there in Alain. And I'm super jealous about both of them being there. And the third speaker, actually, he is around, I would say, 90 miles above me now. It's just not above, just north of where I'm based now. And as Dr. Saad mentioned, my name is Mohammed. I'm Mohammed Mustafa Mohammed. I'm a consultant anesthetist in the UK now, and I will be with you all tonight. Right. So we're starting with the first lecture for tonight, and I have a real figure, Dr. Yasser Zaghloul. I personally enjoy listening him to a lot of other lectures. I hope I will meet him in person in one of my visits to Emirates, either the Dubai or Abu Dhabi. He's a senior consultant in anesthesia and ICU director of Abu Dhabi Anesthesia Club, Sheikh Khalifa, Medical City, Abu Dhabi, United Arab Emirates. He's really a talented speaker, and he keeps enriching us with a lot of really hot topics, which is extremely fundamental for every anesthetist to know more about. And tonight, he is teaching us about heart failure in non-cardiac surgery patients. And we all know that heart failure is a deadly syndrome affecting at least 2 to 3% of the population, especially in the prevalence of the elderly. And patients with heart failure undergoing either elective or emergency non-cardiac surgery in modern surgical setting have a substantial mortality risk. So it's one of these really dark areas, which is any anesthetist will be really, really getting worried when facing such patients. So I will keep you entertained with Dr. Yassir for tonight, and I'm sure 100% I will be personally learn from a lot from him. and shed a lot of light on this hot topic. So it's over to you, Dr. Yassir.
Okay, thank you so much, Muhammad Mustafa, and thank you for Saad Mahdi for this chance to present my talk. And as you see, the title is a little bit difficult, heart failure in non-cardiac surgery patients. Anyway, here we can see the overview of my lectures, short introduction. What is the definitions, type, and stages of heart failure? The essential for anesthesiologist, not in too much details, the general management of heart failure as a perioperative risk factors. Everybody is aware about that. And the perioperative anesthesia concern if the patient coming with acute or chronic or compensated or decompensated heart failure, then we will talk shortly about some types of cardiomyopathy and heart failure. So first, I am not a cardiologist. Heart failure is a major issue. As you can see, more than 7 journals every month talking about the heart failure only. It is a major subspecialty in cardiology in general. But again, I have to select the information or the knowledge which is essential for every anesthesiologist. One of the recent publication about the European Society of Cardiology about the guidelines, diagnosis, treatment of acute and chronic heart failure. And I got many informations from these articles, and it is well written. And I advise everybody interested in heart failure to read this article. Generally, in United States, the patient with heart failure more than 20 years is about 60 million. And every year they diagnosed 1 million of new patients with heart failure. And despite the progress in medicine and the technology and in pharmacology, still the mortality rate is high in all age group and both sex. Generally, the annual cost is $30 billion per year, and it is the most common reason for hospital admission for patient more than 65 years. So it is a major medical problem. Mortality is still high from 20 to 25% in patient diagnosed with heart failure. And heart failure is recently diagnosed as a clinical syndrome, and you have symptoms like shortness of breath or easy fatigability, and you have the signs of increased jugular venous pressure, pulmonary edema, and peripheral edema. And at the same time, we have structural or functional abnormality in the myocardium, and we will explain some difference now about the structure and functional abnormalities. And of course, the intracardiac pressures will be high and inadequate cardiac output, with affecting all the organs of the body and will limit the exercise of the patient. The most simple classification of the heart failure or systolic and diastolic. This is the old one. In systolic one, as you see, the heart is thin, and diastolic, the heart is thick, but in both situations, the blood pumped by blood is limited, and the contraction in the diastolic dysfunctions is normal, but still the blood pumped is less. Now come to the recent classification. We have 3 types. Reduced ejection fraction, this is less than 40%. Mild reduction in the ejection fraction between 41 to 49, and preserved ejection fraction more than 50%. A little bit strange how to have patient with heart failure and the preserved ejection fraction. We will explain this very soon. Actually, because we have a lot of chronic medical problem which affecting the heart, diabetes, hypertension, COPD, chronic kidney disease, obesity, anemia, long-term depression, all these lead to some changes in the heart, impairment in the feeling and the relaxation, atrial dysfunction, dynamic mitral regurg, vascular dysfunctions, and pulmonary hypertension. So despite there is no structural damage of the myocardium, but still we have functional abnormality. That's why we have patients with heart failure and preserved ejection fraction or more than 50%. And of course, if you have more clinical problems, the possibility will be high. Now, I am discussing some case happened with me. This patient is 64 years old, hypertensive, diabetic, dyslipidemia, obese, mild anemia, hemoglobin 11.2. And he is in enalapril, oral hypoglycemic, and statin. This patient coming for bilateral total knee replacement, and it was done with combined spinal epidural, propofol TCI sedation guided by bispectral index. I used phenylephrine to maintain MAB more than 65 or 70, surgery 4 hours, and the blood loss at the end is 400, and he received Ringer lactate 1.5 liter. So is this patient at risk for perioperative heart failure? I can hear you, most of you may be yes, but yes, why? We have now to see. Now we have what is the cardiac complications which occurs with major non-cardiac surgery. Actually, it depends on the 4 factors: preoperative, surgery, anesthesia, and the postoperative. Preoperative, as you see, patient coronary heart disease, chronic kidney disease, hypertension, heart failure, atrial fibrillation, recent stroke or MI, coming for emergency surgery. Surgery and anesthesia, we are aware they have a lot of systemic changes due to the sympathetic nervous stimulation, bleeding, inflammation, cardiovascular instability, hypoxemia, hypothermia. Postoperative factors still risk factors for cardiac complication due to the hemodynamic instability, desaturation, pain, bleeding. And at the same time, most of the cardiovascular drugs is stopped preoperatively. This leads to the mismatch between oxygen supply and the demand, and there is some possibility of coronary artery thrombosis and arrhythmia. So the end result is myocardial ischemia and infarctions, and this may extend to the heart failure and the cardiac arrest. So remember this slide well, the preoperative, postoperative anesthesia and the surgery, this is causing most of the problem in patient coming for non-cardiac surgery. How can I know the severity of heart failure? If some patient coming for me and he told I have heart failure, what the stages, what is the severity? We have 4 stages. Stage 1, or stage A, the patient don't have actual heart disease. He has the other comorbidities. That's why the treatment is directed to the control of blood pressure, sugar, reduction of the body weight, and giving statin for metabolic syndrome. Stage B, the patient has already heart disease, maybe all the MI or ischemia, left ventricular failure, reduction in the ejection fraction, valve disease. At this situation, you are giving ECE inhibitors for all patients. You may need to give aspirin. Beta blocker is indicated in some patients, plus or minus statin according to the cholesterol and the lipid profile. Stage C, this is the patient already has signs and symptoms of heart failure. So shortness of breath, fatigue, exercise intolerance, maybe renal impairment as well. So you have to add another medication like diuretics, aldosterone antagonist, digoxin. Patient may need pacemaker, and it is indicated ICD and the pacemaker in patient with ejection fraction less than 30%. Actually, this is a little bit old recommendation in 2017, as we will see now the new recommendations if it is less than 35. So give a little bit higher safety margin. Stage D, this is the most worst one. The patient is not responding to the medical treatment and he may need long-term hospitalization, and this is potentially for heart transplantation if available in some countries. So this is the main 4 stages of heart failure. According to the new guidelines, they added 2 new drugs for the management. Everybody is aware about beta blocker, ECE inhibitor, statin, digoxin, diuretic. But there is no new group of the drug added to the heart failure patient with reduction in the ejection fraction. The first one, dabigloflozin, this is an sodium glucose co-transporter inhibitors used in the diabetes type 2. The second medication is Versigat, which is cyclase stimulator and enhances the GMP pathway. And the second one is indicated in patient with NIHA group from 2, 3, or 4, not responding for the conventional treatment. You give all the medication to control the heart failure, But in this situation, patient is not responding, you may add Versi-Gut. Regarding the first medication, the dapagliflozin, this is the glucose, sodium glucose co-transporter inhibitors. The main effect, everybody's asking how the anti-diabetic effect may improve the heart failure. The main issue that for the transporter inhibitors is the reduction of the absorption of sodium and glucose by tubules from the kidney. So increase the sodium and glucose excretion, decrease the burden and the load of the kidney. So the end result after many changes improves the ventricular functions. In the same time, the kidney, when it is loaded by glucose, the production of erythropoietin is reduced. When the transporter inhibitor is used and there is more excretion of glucose, the EPO-producing fibroblast recover its functions, so erythropoietin will be produced more and it will be increased the hematocrit. In short, increase the sodium and glucose excretions, improve the ventricular function. That's why the transporter inhibitors added to the patient with chronic heart failure with reduction in the ejection fraction. I can hear many asking that this is in patient with diabetic. Can I use it in non-diabetic patient? Actually, yes, because it is not reducing the blood sugar. It is not causing hypoglycemia. It improves the renal tubules function regarding sodium load and glucose load. And in this recent study or meta-analysis, they found that also when you are using the transporter inhibitors, in case of non-diabetic patients, it improves the metabolic parameters with reduction of the body weight and the blood pressure, again, in non-diabetic patients. Regarding the Versi-Gut, how it improves the functions of the heart, generally in patients with heart failure, we have endothelial dysfunctions, oxidative stress, inflammation. This impairs the nitric oxide. So we have GMP deficiency, vascular dysfunctions, and myocardial dysfunctions. Once the patient has Versi-Gut, this will enhance the GMP pathway and increase the GMP concentration. So it will reduce the left ventricular hypertrophy, causing vasodilatation, and it increase the renal blood flow. So we understand now why these two medications is added to the patient with heart failure. Beta blocker also is important medication and should be used in all patients with heart failure and reduce the ejection fraction, but it should be initiated in small doses gradually. And if the patient is not beta blocker preoperative, it should be started at least 1 week before the elective surgery. And of course, it is contraindicated in acute decompensation, heart block, and bronchial asthma. Another option in the treatment of heart failure is resynchronization therapy. And as I mentioned, recommended in ejection fraction less than 35% and prolongation QRS more than 150 seconds and left bundle branch block. So now we understand the general management or treatment of heart failure. Heart failure as a preoperative risk factor is well known since more than 45 years when Goldman implanted his risk index and he put heart failure in the top of all the risk factors. You can see MI, non-serious age, emergency, but whatever the heart failure is the most important risk factor. Also, Lee's index puts the same congestive heart failure on top of the risk factor for patient coming for non-cardiac surgery, in addition to the ischemic heart disease, transient ischemic attack, and the stroke. Patient needed insulin for diabetes, or there is a renal impairment. And of course, decompensated heart failure is a absolute contraindication for elective surgery. If you have a patient with decompensated heart failure coming for emergency surgery, we will discuss it very soon. Now, if the patient coming with heart failure for non-cardiac surgery, whatever the heart failure controlled or not controlled, what is the outcomes? This recent study reviewed more than 21 million patients. Can you imagine the all the file of more than 21 million patients coming for non-cardiac surgery, more than 18 years with review. They found heart failure in about 5% of the patients. This means about 1 million. What is strange in this study? The patient who has acute heart failure, this has the highest mortality. That means the patient don't have chronic heart failure before. Like, as you see, acute heart failure, this is the higher mortality, 8%. Chronic heart failure and decompensated to acute, less mortality. Chronic heart failure only without development of acute heart failure, the mortality is less. Intermediate heart failure, this means maybe mixed with other problem like pulmonary embolism, the same one. Adjusted odds ratio is 2. In short, acute new heart failure during the pre-operative period is the highest mortality, and we have to explain it, of course. Now, if the patient has myocardial injury and developed congestive heart failure, the mortality is high, is about 9.4%. And the myocardial injury, we mean ischemia, infarction, heart failure, serious arrhythmia, cardiac arrest, or cardiac death. These 5 points for the myocardial injuries in non-cardiac surgery. And again, we have to stress the congestive heart failure with myocardial injury has high mortality up to 10%. They found here the main problem in the patient is the oxygen supply demand mismatch, not thrombosis. And as I explained before, the hemodynamic changes or hypoxemia or arrhythmia or anemia and the factors which may increase oxygen demand like pain, fever, shivering, agitation, and this is the main problem which may cause the ischemia and infarction. Also, if the patient has heart failure, there is high risk of postoperative acute kidney injury because of the bleeding, positive pressure, anesthesia, volume loss, and in the presence of anemia, surgical injury, all these predisposed to the acute kidney injury. The problem, again, it is maybe difficult, and the presentation is not typical like in medical patients, and as you see, the factors is completely different than the medical patients. That's why it may be missed or not diagnosed in good time. What is our anesthesia concern for patient coming with heart failure? First, I know there is 2 lectures now about enhancing recovery after surgery, but I like to name it improving recovery before surgery. This means the proper optimization and intervention which avoids the intra and the post-operative complication or any problem. Anyway, in a patient of heart failure, it is logic to ask the cardiology consultation and evaluation, continuation of all medication, including the day of surgery, except the anticoagulant or maybe C inhibitors in some patients. But generally, you have to continue all the medication. If you have to stop some medication, this will be discussed in another lecture. Optimization of all the comorbidities in the patient, especially blood pressure, hypertension, diabetes, COPD, and anemia. If the patient at higher risk, you have to discuss it with the patient and in the family. And even simple intervention can improve the outcome, like reduction of the body weight and the controlling of the chronic pain before surgery and exercise. For exercise, for example, if the patient doing exercise for 2.5 hours per week, this means about 30 minutes for 5 days per week, you can see the lot of improvement in the general functions. Improve the respiratory muscle, increase cardiac output, decrease resting heart rate, decrease sympathetic tone, increase vagal tone, improvement in the endothelial functions, decrease inflammation, decrease insulin resistance. Anyways, something is very simple and can improve the patient functional capacity before elective surgery. Anemia is a major issue also, and as you know, it is defined by the World Health Organization, less than 30 in man and less than 12 in woman. And it is recommended all patients with major surgery and expected blood loss than 500 to investigate and to treat the anemia. And usually the recommended target to be more than 130 in all male and female patients. This, as you see, it is a consensus about the international statement by many authors from different countries. So it is not a personal opinion regarding the essential management and improvement of anemia in patients in general and specifically in heart failure. And I will come back to the anemia again in patients with heart failure. Patient should be assisted for echo. BNP should be assisted as well because it is prognostic. Patient coming with high BNP, higher mortality or higher morbidity or higher risk of decompensated heart failure. And if the heart failure is newly diagnosed, it should be treated for 3 months before coming to the elective surgery. Again, for emergency surgery, we are coming for it. This is the standard preoperative treatment in patients coming with heart failure according to the European Heart Journals 2 months before. BNP or pro-BNP, ECG, echo, chest X-ray, and electrolytes, blood count, thyroid functions, glucose, lipids, and iron status, and dust disease transferrin saturation. Again, this to see the iron store and if this patient is liable for anemia or no. So this is the standard for heart failure patient to investigate preoperatively. Something is very strange in medical patients. The most common factor for decompensation of heart failure is the anemia. As you can see, if hemoglobin than 10.9 is responsible about 36 or maybe 64% of decompensation of heart failure. Other ischemia, this improper food intake, this patient high sugar or lipids or high cholesterol, valvular dysfunctions, infection, drugs, starting new drugs like calcium channel blockers or beta blockers have negative inotropic effects, so it may decompensate the heart failure. And may be important for us, the blood pressure more than 140/90 or poorly controlled diabetes also is a risk factor. This is in medical patient, not in surgical patient. But of course, we have to consider it in our patient coming for anesthesia. That's why the target should be more than 130 if the patient coming for major surgery to limit the blood transfusion. Another recent article about the preoperative anemia and the myocardial injury after non-cardiac surgery and divided the patient to 3 groups, hemoglobin more than 30, the myocardial injury about 14%. From 11 to 13, it is 21%, moderate to severe anemia, and it is defined as hemoglobin less than 11. The myocardial injury is about 30%. 1/3 of the patient coming for non-cardiac surgery with hemoglobin less than 11 may develop ischemia, infarction, arrhythmia, heart failure, cardiac arrest, or even cardiac death. So we should consider anemia seriously, not just a figure or number. Now, the more explanation about the anemia and the effect in heart failure. This is the normal relationship between oxygen delivery and oxygen consumption in normal person. The hemoglobin from 13 to 7, critical oxygen delivery. This means anaerobic metabolism and reduction of oxygen delivery occur at hemoglobin 7. This is in normal person. If the patient has heart failure, this shift to the right, and critical oxygen delivery may occur at 8 or 9. Heart failure plus anemia may occur at 9, at 10, and multi-organ failure with heart failure and anemia may occur more than 10 even. So patient coming with heart failure and anemia, very critical oxygen delivery can occur at high hemoglobin level that you may consider it is okay or the patient's compensated 8 or 9, but he may develop anaerobic metabolism at the level of 9 or 10. Another important issue for hemoglobin and RBCs, you may ask why I am giving blood. I'm giving blood to increase the oxygen delivery. No, it is not the only issues. Everybody of us forgets the other important physiological factors of RBCs and hemoglobin. Hemoglobin is the primary oxygen sensor and the modulator involved in nitric oxide activation and deactivation. That means it is important to maintain the vascular tone. Now, if the patient is coming for any surgery and occurs intraoperative hypotension for any reason, hemorrhagic shock, septic shock, hypovolemic shock, and you are starting to give vasopressor, nor epi, or phenylephrine, or vasopressin, or whatever, and the patient is not responding simply because he is anemic. You don't have the hemoglobin, which is essential for oxygen sensor and demodulator of nitric oxide to maintain the vascular tone. Enough for anemia now. Acute postoperative pain is another problem, may cause myocardial injury, and they found that troponin increased in about 5% with myocardial injury in around 3,000 patients within 72 hours, simply because of poor pain control. And this because the significant sympathetic stimulation and side effect of uncontrolled pain, which may increase the myocardial work, hypercoagulation status, may cause DVT, pulmonary embolism. In short, poor control of pain within 72 hours, causing myocardial injury in 4.5% of the patients. Intraoperative hypotension with drop more than 50 millimeter mercury increased 20-fold risk in the clinically significant perioperative MI. And MI, if not diagnosed, not detected, will progress for heart failure and even for cardiac arrest. So if you have a patient coming for surgery, which type of hemodynamic monitoring? If low-risk patient and low-risk surgery, basic monitoring. High-risk patient or surgery, you need stroke volume variation monitoring to check for fluid responsiveness. High-risk patient, you should have more sophisticated, and you need to check for the cardiac output, systemic vascular resistance, and cardiac end. Simply to know this hypotension due to the hypovolemia or vasodilatation or poor cardiac output or poor myocardial. That's why you have to monitor your patients well. Patient with heart failure for urgent non-cardiac surgery, what you can do? Actually, you have to ask yourself first, this decompensated heart failure due to the acute coronary syndrome or no? If it is due to the acute coronary syndrome, the patient should go to the acute coronary syndrome pathway under cardiology care. See the patient for heart failure. You may have three categories: patient stable heart failure, new heart failure, or decompensated refractory heart failure. Of course, stable heart failure with good functional capacity, you can go ahead for surgery without minimal problem. If you stabilize the patient within 6 to 24 hours stable, so you can go for this pathway, stable pathway. Unstable, you have to continue the heart failure therapy. If the patient still has heart failure and has still indicated for surgery, you have to consider non-surgical management. I can hear you, all of you asking if the patient poor functional capacity or still heart failure and surgery is indicated, should be done. What we can do? See this patient. This one of my patient, 57 years old, came to ER with chest pain, shortness of breath, MI, VF, cardiac arrest, CPR, multiple DC shock, taking for cath lab, and they found left coronary artery occlusion. Stent was done. After stent, the patient in ventilator, echo, severe systolic dysfunction, infralateral hypokinesia, apical kinesia, and ejection fraction in 25%. This is the first day in the hospital. We are not involved yet. But in day 4, the patient still in severe heart failure, in 4 medication, levosimendan, adrenaline, dobutamine, and vasopressin, and he developed respiratory distress syndrome needing nitric oxide, renal failure in renal replacement therapy, febrile increasing sepsis marker, abdominal compartment syndrome, and he was diagnosed septic peritonitis for urgent laparotomy. Is this patient with multi-organ failure is fit of anesthesia? Of course, it's not fit, but there is some surgery should be done. And it was done actually. This is a patient come for OR. You can see he's in nitric oxide 10 parts per million and is 70% oxygen and the beep of 9 and saturation is 93. Difficult to ventilate. Peak airway pressure is 35 and CO2 is 75. Again, because of the abdomen is very distended. Temperature is very high, is 40. That's why we pushed him to the OR, and CVB is 30. Maybe it is not accurate because of the ARDS, high beep, and abdominal compartment syndrome. Anyway, they operated this patient and they found about 2 meters of the small bowel gangrenous, and it needed resection and anastomosis. This because, of course, the patient is hypotensive for a long time and the effect of vasoactive medications. Anyway, it was done resection, anastomosis, and decompression of the abdomen because of the abdominal compartment syndrome, and it was closed later on. Again, I can hear all of you. What is the progress of this patient? Maybe a little bit away from our lecture, but I will tell you. The patient has tracheostomy after 3 weeks, discharge from the hospital after recovery and weaning from the ventilator after 52 days. Hospital discharge at day 93 and with ejection fraction was around 35%. And actually, this patient came after 7 months for repair of the incisional area, and all his organ is working well except the myocardium and this poor ejection fraction 35, and he was in antifailure and double platelet therapy for the stent. So the lesson from this one: never give up. If I win, never lose. I either win or learn. Anyway, if you have some intraoperative heart failure, you have 3 categories of patient: systolic dysfunction, reduction in the cardiac output, and the congestion. Diastolic dysfunctions, the patient may be hypertensive again. He has pulmonary edema and congestion or volume overload. For the first one, you have to use dobutamine, milrinone, plus or minus norepinephrine to maintain the map. Diastolic, of course, you have to use vasodilator to reduce the blood pressure to improve the diastolic functions. And if the patient is volume overloaded, loop diuretic like furosemide or Lasix. The new in the loop diuretics that what is named hyperdiuresis. Hyperdiuresis means you are giving the patient hypertonic saline is around 150 ml of 3% plus furosemide maybe 40 or 80 milligram. And the concept behind that, the patient with heart failure may have hypochloremia. Hypochloremia causes sodium retention and may aggravate the heart failure. And recently, in a patient coming with acute decompensated heart failure, when hyperdiuresis is used, it reduces all the mortality, increases the total urine output and the sodium excretion, shorter hospital stay, and decreases heart failure readmission. Despite of that, it is low to the moderate recommendations, but I think it is good option in the surgical patient to use the hypertonic saline. Most of the surgical patient is relatively hypovolemic, and if you give hypertonic saline, may correct the hypovolemia in the same time. Now we are told that in patients with systolic dysfunction, you may use milrinone or dobutamine, which is best. Actually, in this recent study, they found both of them is the same, but maybe the side effects like stroke, transient ischemic attack, or renal event is a little bit higher with dobutamine, occurs in 54%. But statistically, it is not significant. So if you have milrinone, it's okay. If you don't have it, dobutamine is okay for patient with systolic dysfunction. Now we come back to the orthopedic patient who has bilateral total knee replacement, and I asked, is this patient at risk for perioperative heart failure or no? This is the progress of patient in recovery room. He was awake, no pain in epidural infusion, ropivacaine 0.1 plus fentanyl 2 mic per ml, 6 ml per hour. But unfortunately, after 35 minutes, he developed shortness of breath, dyspnea, became hypotensive, tachycardiac, desaturated despite oxygen therapy, and the blood loss from both drains is around 550 ml. EBG, mild acidosis, VO2 is acceptable. Patient is tachypneic, so CO2 is 32, acidotic, lactates 3.4, hemoglobin dropped to 81. Preoperative, it is 11.5. Diffuse SCG changes in the ECG with BVCs, and when checked for the cardiac enzymes, there is increased CKMB, troponin, and BNP. So what happened to this patient, and what is your management? I can't hear. Okay, so of course, this blood loss causing myocardial ischemia. And again, remember the risk factors: preoperative, surgery, anesthesia, postoperative. All these oxygen supply demand mismatch due to the acute hypovolemia and the anemia. And the patient actually developed ischemia, not infarction. Maybe there is some increase in the cardiac enzyme, but he was normalized after that. So this myocardial ischemia, functional heart failure due to the anemia and the hypovolemia, and 2 units of blood were transfused for him, stabilized within 30 hours. All this is in recovery room. He didn't go yet for ICU. After that, he went to ICU. And the cardiology follow-up for 72 hours with no more cardiac event. So patient with multiple risk factor may be at risk for perioperative heart failure. Now we come to the last point in my lecture. Patient have apparently normal heart with no evidence hypertension, coronary artery disease, valvular or congenital heart disease, and he may develop heart failure. Maybe everybody is aware about the cardiomyopathy, dilated, hypertrophic, restrictive, or arrhythmogenic cardiomyopathy. But every one of that need maybe half an hour at least to talk. But actually, I am not talking about this type of cardiomyopathies. So we are talking about what? Again, remember why patient with acute heart failures had 80% mortality. Simply, we are not expecting this group of patients to develop heart failure. So which group of patients? This one, patient with chronic health problem, hypertension, diabetes, obesity, cirrhotic liver, patient with chronic kidney disease, chemotherapy, alcohol. And it may occur acute, like in patient with sepsis, post-peripartum, tachycardia or stress cardiomyopathy, neurogenic stent myocardium, which may occur with subarachnoid hemorrhage, stroke, or TPI or ECT, negative pressure pulmonary edema in patient with severe stridor and during thoracic surgery. Of course, I will not mention all. I just mentioned a few points about some topics. We have to differentiate between cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. And the non-cardiogenic pulmonary edema, fortunately, due to the reversible myocardial dysfunction. So it can be treated. The most common example is the neurogenic stent myocardium due to the acute brain injury. We have massive sympathetic nervous stimulation, and systemic vasoconstriction is very high, and also pulmonary vasoconstriction. The end result is pulmonary edema due to the increased permeability and increase the pulmonary capillary pressure. This is one of the examples. And of course, you have to treat the cause for this patient. Septic cardiomyopathy, due to a lot of problems, especially adrenergic receptors, down regulation. Just 3 minutes, okay? Down regulations of the mitochondria, coronary microvascular changes, and mitochondrial dysfunction. The end result is that the patient has left ventricular hypokinesia and ejection fraction less than 40 or 45% in 50% of the patient who are completely normal before the sepsis, no heart disease. And the management is norepinephrine to maintain MAP more than 65, and you may add vasopressin if not responding for norepi. And if cardiac dysfunctions, you may add dobutamine or epinephrine. And the recent recommendation, you may use the vasoactive drugs in peripheral vein. Diabetic cardiomyopathy also increase the mortality to 3-fold in patient coming for surgery. And this diabetic cardiomyopathy occur in 1/4 of type 1 and 1/3 of type 2 diabetic patients. What is the manifestation? Patient may have tachycardia, exercise intolerance, orthostatic hypotension, cardiovascular instability, and everybody is aware about the ischemia and the infarctions, which is silent in diabetic patients. When to expect it? We have a lot of diabetic patients every day. Patient poorly controlled, chronic hyperglycemia, patient with retinopathy and the nephropathy, high incidence of cardiovascular autonomic neuropathy, and history of heart failure. Actually, it is gradual. And first, it is subclinical. After that, increase due to the denervation of the parasympathetic fibers. When parasympathetic and sympathetic denervation, we have more complication. Resting tachycardia, impaired exercise tolerance, and the more severe orthostatic hypotension. Obesity, cardiomyopathy, again, we have lipotoxic heart disease, and this affecting both sides of the heart. The right side of the heart, due to the obstructive sleep apnea, pulmonary hypertension, right ventricular hypertrophy, and affecting the left side again because increase the load and the cardiac output. So right and left heart, we may have right heart failure and left heart failure, and some patients will come with biventricular failure. Maybe not common, but still a big problem in obese patients. And the higher the time or the duration of obesity, it's like more than 10 years, the higher the incidence of the obesity cardiomyopathy. And it was recommended to do preoperative echo for evaluation if the obesity more than 10 years, if the patient has suspected signs of heart failure, arrhythmia, and even if the patient coming for major surgery. Cardiomyopathy, we have 3 stages: reduced cardiac functions, compensatory phase, and the cardiac phase. First, the patient is hyperdynamic state, then patient tachycardia and the palpitations, then he will develop heart failure and the pulmonary edema. And the echo here, just isovolemic relaxation time increased. He has diastolic dysfunctions. He may have diastolic and systolic dysfunction. So patient with cirrhosis needed also to be evaluated for cardiac functions. Chemotherapy, patients in a lot of medication for chemotherapy, and all the, or almost all the drugs used for chemotherapy in oncology has cardiomyocyte damage and heart failure. These another cardiovascular effect which may prepare for heart failure as well, like thromboembolism, arrhythmia, hypertension, ischemic heart disease, valvular disease, pericardial effusion. All these may predispose to the heart failure. Cardiomyopathy, this is the last point of my lecture. Here, the systemic review of published cases, it was found in 93 patients. Mostly it is female. Can occur with general anesthesia, neuroaxial sedation, and in some cases not reported. Heart failure in 57% of the patient, and we may have some complication like arrhythmia, stroke, or cardiac arrest, and it can occur at all the time of anesthesia. The strange here, 58% occurs postoperative, and the highest in the first, during the surgery day 0, 37%, this is the higher. But you can see it can occur at all the stages of the anesthesia. And there is many triggering factors, maybe the most important in depth of anesthesia, intubation, extubation at very light anesthesia, if you are using exogenous catecholamine, if the patient has anaphylaxis, during electroconvulsive therapy, very high CO2, and use of ergotamine in cesarean section, cardiac arrest, spinal cord stimulation. Now,
time is running.
Yeah, summary of my lectures: perioperative heart failure, reduce the incidence of, you have to continue all the medication, reduce the incidence of the left heart failure, prevention and early management of all the factors we mentioned, which may precipitate heart failure. And heart failure may occur in some groups that I explained some of them without history of heart failure. So if you cannot explain it simply, you didn't understand it well. So did I explain it simply? I hope so. Thank you very much. I am very sorry for long time. Nobody here?
Dr. Yassir, thank you very much. This is looks like you put a lot of efforts for this presentation. A lot of efforts. Thank you very much, and a lot of clever nomenclatures and terminologies, a lot of drugs and mechanisms and all this stuff, which is so thank you very much. It's really fantastic. Thank you. I have just because of the time, I will.
I know I take some a long time. I am very sorry, but you can. I can write the answer. I can answer one, and I can write the answer for one. It's up to you.
Okay, so let us just leave the question answer part for you, Dr. Yassir, to answer it in person. Okay.